Hello everyone and a warm welcome to today's webinar for 𝗫𝗫. Today we are going to have an introduction to what is 𝗫𝗫 exam and how you can approach this exam. And also we are going to discuss about acute leukemia. We have our special guest, Dr. Nida, with us. She is going to introduce to you about the topic and how you can approach the exam. So I would like to request Dr. Nida, please can you continue?
Hello. Yes, I'm Dr. Nida, and thanks Asma from your about your warm welcome. So today we will discuss about what is exactly 𝗫𝗫 and how you will get approached toward the theory exams and how it will benefit you. So let's start. This webinar is about what exactly 𝗫𝗫 is exactly. Okay, so 𝗫𝗫, what exactly is a membership exam of the Royal College of Physician and Child Health, and what you exactly get that after having this exam, you will get, the GMC registration. So when you will have this 𝗫𝗫 full, along with this theory and clinical, you will exempt from the PLAB exam, the PLAB 1 and PLAB 2. And after that, you are allowed to do the basic. After that, you can go ahead with your pediatric training, and you after a few years, you will eligible even to go toward the fellowship exam of Royal College. That is really worthful. Now, why we choose this 𝗫𝗫 exam? Because this is an essential component and you can go ahead with the training in the UK, and it is whole soul map in the UK curriculum. And you can get after that, after the clinical exam, you will have you can get the GMC registration, as I told you, and its whole exam, it's based about the evidence based as well as the latest research based exam, and it's really up to date exam. Now, why we choose this exam? Because this is it's a very prestigious membership exam of Royal College, and you can get the entry in the whole UK, NHS, or everywhere in the Europe, and after that, and it's more or less, it's widely internationally recognized. Like, you can go ahead if you are moving towards, and if you are in Middle East, so it's considered to be a very prestigious degree. And in Europe, you can go ahead also. But for European countries, you should, over the full command over your language. Or which country you are moving. But overall, it is acceptable, except that US. Now let's talk about the 𝗫𝗫 component. Actually, this membership exam, it consists of the theory exam. It's membership exam. It's basically it's a theory exam, and it consists of the 3 theory parts. The first one is the foundation of practice. The second one is the task, that is theory and science. And the third one is the applied knowledge of practice. And this all, after passing 3 theory exam, you will applicable to go ahead with the 𝗫𝗫 clinical exam, that is the OSCE type. Let's talk about this, the foundation of practice first. Foundation of practice, they have changed the pattern of foundation of practice, and in this foundation of practice, they really, they judge your basic knowledge of pediatrics. So if you rotate in your pediatric ward at least for 3 to 4 months, then you will have the sufficient knowledge, basic knowledge, and they have provided they have their certain books that it will, it's really amazing to go ahead. Okay, am I audible? Audience, am I audible? Hello, am I audible?
Yes, ma'am, you are audible.
Okay, because somebody told that am I not audible? So sorry for that. Maybe there is some internet problem. So foundation of practice, this is the basic fundamental of pediatrics, and they have changed the theory pattern of theory exam. Before that, there were extended matching questions, but now there's only one best question. That all of them are correct. You know that, but one you have to choose which one is the best, and it consists of 120 minutes, and there will be 100 marks. And each question will mark 1. So the percentage of foundation of practice is really high. So but it is percentile, but more or less is around sometimes 65%, sometimes it's 72%. So it's around that. Now let's talk about the theory and science. Before that, also there were so many questions, and the exam consists of extended matching questions. Now they have changed the pattern that it consists of 101 best questions, and they have short the duration like 120 minutes. There will be no extended matching questions. Let's talk about the theory and science exam. So what is exactly theory and science exam? It's all about the basic physiology and basic anatomy of related to pediatric. Like they can give you the cardio circulation, they can give you the physiology of fetal circulation. So it's all related to it, but you can come across the pathophysiology in the theory and science. And one more thing I want to tell you about the Part 1 exam, that in each year they conduct the exam in 3 times. And for theory and science and foundation of practice, you can give in the one go also. Like morning, they usually conduct the foundation of practice, and evening they are conducting this theory and science. So if you are prepared enough, you can go ahead with the one flow also. So it will, it will very budget friendly for you if you will book both the exam. And I want to tell you about one important thing that is very necessary, that if you are new and you want to register yourself, please register the exam date, I think 3 months ahead, because they will take some time to register you. And not just before 1 month ahead of the booking video, because it takes some time, because they will check your primary degree verification and all. So it's very necessary that you register your exam, I think 3 or 2 months ahead. So let's talk about applied knowledge and practice. Applied knowledge and practice is it's a different one, and we usually call it part 2. It's up to you that whether you can apply for. First, you can go for part 1, and you can go to the part 2. There is no hard and fast rule. As I have done the AKP first, and then I will go towards the FOP and the task. So it's depend upon your clinical practice, and it's depend upon how you have the grip, how you have the knowledge and grip of the syllabus. Applied knowledge and practice consists of one. We have also changed that 150 best questions, and it consists of 2 parts. I'm sorry, that part 1 and part 2. And you cannot break the exam in 2 parts. You have to give the exam in one go, that part 1 and part 2. Even that this is the second part of theory part of MRCP-CH, you have to give in whole soul in 1 day. And but the total number of marks in total, they will give you the full marks. So it consists of 2 parts. Now nowadays they have changed the online invigilation eligibility requirement. Before the COVID era, we used to book the exam from our home, where you are in the world, and they book you the seat. They have given you the seat. They just book the slot, and you can have your seat, just payment and all. But nowadays, because of the number of candidates have been increased so much, so they have put a certain criteria, like from 2024, that if your country has the center, then you have to fulfill 3 criteria. Suppose that if you are in Pakistan, I will give you one example. that if you live in a certain area, there are no centers, so there will be 200 miles away from your residence. So you have to provide them evidence, either in the form of utility bills or in the mortgage or the tenancy agreement, whatever. They will not accept their NIC card or any kind of passport of residence. They actually need the evidence that you are live far, your residence is away from the center. Fortunately, in Pakistan, we have the centers in Islamabad, Rawalpindi, and Lahore. So, if some people are living in Islamabad, Lahore, and Pindi, they will give you the seat in the centers, and you can apply the overseas window. So they will give you the seat, but you have to provide the evidence. Now, so we will talk about the foundation of practice today. So foundation of practice, in not only the foundation of practice, but in every theory exam, there is some fundamentals. So if you are thinking to give the exam, and if you want to prepare, then you have to full command over this 6 pillars. These are, I must say that this is the 50 clinical cases for foundation of practice. And there for the theory and science, there is also 50 clinical cases. And for the applied knowledge of practice, there is also 50 clinical cases. There are few topics that are very fond of asking these topics. Suppose that in hematology, they frequently ask, for example, that leukemias, they are very, they are pets. So they love and they ask in whether in the FOP, whether in the task, whether in the applied knowledge of practice. As far as books are concerned, they have some textbooks, but choose one textbook and stick to it, and but read it thoroughly, that you know each and every corner of that book. For foundation of practice, you can read survival guide, you can read illustrated book of pediatrics. So these and for theory and science, there is SOP that we call SOP book is the science of pediatrics. And for the applied knowledge of practice, again, this is survival. There's a book called the survival guide. Guidelines. Guidelines are very important. If you are going toward the exam of MRCPCH, then you have a full command over the guidelines. Either you are giving the POP exam, either you are giving the TAS exam, either you are giving of applied knowledge, as well as for the clinicals like OSCE. Guidelines, and they keep updating after 2 years. So, and they are very particular about their guidelines, that if something is written in the guideline, you should be very very precise, and you should give the answers according to the guideline. And it keeps changing after 2 years. That right now there's 2020 pediatric guideline, that is blue text, there's blue cover over it, and it's valid. It's 2022. So after 2 years, it will become changed. Now come towards the MCQs. For MCQs, you can go ahead with the past test, and you can go the BMJ. But if you are solving the MCQs, you just read the topic and you just solve the MCQs. But for the MCQs, past test, you should read the explanation also. So it will give you the clear concepts about the MCQs and the clear background of the knowledge. But keep in your mind that few topics are very important. So like in respiratory, cystic fibrosis is very important for them. Now recalls. I must say that you must need a mentor for the recall, and you have a good team to solve the recalls, because recalls are recalls. They are just the recalls, and some things are not correct. Some statements are incorrect. Some stem is also not correct. So you have a full command, and you should know the full background knowledge about the recalls. Now let's move towards our topic, that is our clinical case. The clinical case that I spoke to you, that the pillars of foundation of practice is whenever you are studying any topic, like suppose you are studying the hematology, then you just name in the clinical case, there are a few clinical case about the hematology. First read that clinical case, then you read that topic from the book. Then you have a full command over that topic, because you will have the clear-cut idea that what exactly they are asking and what are their favorite points and they want to, and what are their, sometimes they are giving you the dodges also, there some distractor also. So you should know the what are the tricks, what are the ifs and buts of the MCQs. So let's solve this clinical case. It's about the Chloe, and she is a 3-year-old girl present to her local district general pediatric department with a 2-week history of increased tiredness, and she has developed a limp on the day of the presentation, and she has developed spontaneous bruises on her abdomen, back, arms, and her leg. Her parents feel that she is stingy and not her normal self, and she has no significant past medical history. On examination, she is pale with a warm peripheries. She has a 2/6 systolic murmur, as noted, and the loud, I cannot read that, loud, and the loud murmur, I think so, and the upper left sternal edge. Her temperature is about, her temperature is about 37.6. Her heart rate is 110 beats per minute, and she has a normal blood pressure, and there is no respiratory distress, and her chest is clear. She has a 3-centimeter liver edge and 2-centimeter spleen edge palpable. Her abdomen is soft and non-tender. So that type of MCQs usually come sometimes in POP, but more probably with the data, it comes in the applied knowledge of practice. But this is a clinical case of foundation of practice. I will tell you the case number also. Case number is 35. So they have given you the data also. Sodium is 136 millimole, potassium is 3.8 millimole, urea is 6.5 millimole. Yes, and one more thing I want to tell you that they measure these things in millimole. So try to be more climatized and habitual of this units. LDH is 450 unit per liter. AST is 32, ALT is 28, albumin is 34, chloride is 111 millimole per liter. Hemoglobin is 65 gram per liter, and white blood cells count are 53, and platelet is 24. So, seeing all this picture together, what is in your mind actually? A child, a 3-year-old girl, and she has a not that much long history of limping, and she has some bruises, and she has some problem that she has murmur also, and you can interpret that she has anemic, and she has some infection, and her platelet count is very low. So let's think about, so this is a brainstorming. So what do you think that what is most likely diagnosis? This is a case from the clinical case of foundation of practice. So most likely diagnosis, I did not give you any options because just think about rationally that what it can be. So actually what it is a child who is having this acute lymphoblastic leukemia. Maybe you're surprised that why they have given us the murmur and all. Sometimes they give you the distractor also. This is the distractor. So be aware, and sometimes in applied knowledge of practice, they give a lot. What investigation is most important prior to the regional children's hospital? So which investigation before transfer, the answer will be, they have given you, they usually give the 5 options like A, B, C, D, E. And nowadays there is no extended matching questions. So the correct answer for this, before transferring, you have to do the X-ray chest. Okay, there will be the, there will be the secondary manifestation, there will be some chest involvement, metastasis. So prior to transfer, regional children's hospital, we just think about it. Now, which treatment is most important to commence transfer to the regional children's hospital? Because what do you think that what treatment is most important? Because the child has some problem that maybe she is leukemic. So there is something that if you will not give her, then there will be disaster for her. That thing is the hydration. I will talk about that, why we are not thinking about this chemotherapy, why we are not thinking about the antibiotics, why we are not thinking about and why we are thinking about this hyperhydration. Let's solve all these things together. So this is our topic. This is called acute lymphoblastic leukemia. This leukemia is, it's very common. It's 30% of the childhood cancer. It's very common topic, and you may come across in the foundation of practice. You can come across in the theory and science. You can this will come up. This can come in the applied knowledge, yes, and also in the OSCE exam or in the video station. Now, 85% are acute lymphoblastic leukemia. The age for this acute lymphoblastic leukemia is 3 to 4 years. And what happened to the in leukemia? That is a proliferation of the stem cells, and it become a weird type of cells that is transformed. All we know that the signs and symptoms are, they usually give the short history, and the age is very 3 to 4 years. There will be 𝗵𝗂. The WBC count is usually high. Most of the time it's high, and the child looks pale, tired, and platelet count is decreased. There is a history of the weight loss. There will be lymphadenopathy. There is some anorexia. There is some headache, and nausea. When you think about the headache and nausea, what comes in your mind? That there can be chance of this may spread to the central nervous system. You just think you should be very alert about that. Now, what investigation that you will do? That not in that case, but here is a general. So full blood count with peripheral film. What you will find in the peripheral film, that there will be the blast cells will be increased. If you will find blast cells, then you should be very curious why this blast cells came in the peripheral film. Most of the time, WBC counts are increased, but it may be sometimes normal or decreased, but mostly it increased. Platelet count is usually decreased. In bone marrow, there will be some. In bone marrow, we usually do, and in CSF, we may come across there is blast cells, and coagulation screening. Of course, you will do as an investigation. And the answer of our scenario is X-ray chest, because the child is moving from one center to another, and in the previous center, all tests has been done previously. That was understood. Now move toward the another slide. Now comes toward the very important question that being asked in the foundation of practice and theory and science is prognostic factor. This question is frequently asked in the OSCE exam also, and it's a very favorite question for foundation of practice, that they usually ask this question like that. I will give you an example. Following are the poor prognostic factor of acute lymphoblastic leukemia, except. Or the question can come like this: following are the prognostic factor, and they will give you one odd. So the examiner, this is very pet question, and it's frequently asked in the exams, theory exams mostly. So I have made an mnemonic for you, how to memorize this. I'm very fond of making this mnemonic, this prognostic factor. Prognostic factor mnemonic is MBA, BA, and CM all go to HR. So whatever we are, we have to go ahead for the HR for our jobs, and for getting ourselves in working conditions. So MBA, BA, CM all go to HR. So let's talk about this MBA. MBA is a male gender, and B is for the B cells having, if the tumor is having B cells, then it's worse prognosis than T cells. Now, A is age is less than 1, and if more than 10. Suppose if the child comes to you with some infant age like 8 to 10 months, then the prognostic factor is more. And if the age is 12 years, then the prognostic factor will be more. Now, the BA. What is BA? BA is a black child if the child is African, or ethnicity is from the Africa, or he is black. So he has a more chance of the prognostic factor will become more as compared to the other ethnicity. Now, talk about this A. A is an abnormal chromosome that, if Philadelphia chromosome or other, then prognostic factor will become increased. WBC count is if it is more than 50. That in a clinical case, the WBC count I think is very high. So there is a poor prognostic factor. Now there is a triple C for that. That is cytogenicity, then CNS involvement, and the last one is morphology. If it is more toward the L3, L2, and L3, then have a poor prognosis. This prognostic factor has been asked several times in Foundation of Practice, Theory and Science, and Applied Knowledge of Practice, Applied Clinical Knowledge. Okay. This classification of acute lymphoblastic leukemia is not frequently asked, but let's just try to memorize it. This we classify according to we classify with the mnemonic mass. That morphology is L1 and L2, immunological marker, cytogenes, and enzymes. Let's talk about what comes in your mind when you're thinking about the child is having acute lymphoblastic leukemia, and what you will initially do with that child. So supportive treatment is very, very important. Supportive treatment is like that. When the child is anemic, then you have to treat the anemia. If the child is having raised WBC count, you have to treat the infections. And third one, if the child is having platelet count is decreased, either you transfuse and you have to treat the prophylactic antibiotic. That is very, 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 very important for acute lymphoblastic leukemia. Now, let's come toward the actual treatment for acute lymphoblastic leukemia. Acute lymphoblastic leukemia, it consists of, for the treatment regardless, it consists of 4 parts. So I made a mnemonic again. So this is IIMC. IIMC is stand for actually. So it's the intensification of chemotherapy or remission of chemotherapy. So what is exactly mean that you are giving the you want to give the patient disease free. In we have to give this chemotherapy for 4 weeks, and there are the 4 drugs. I made again mnemonic for the 4 drugs, that is PDA, PDA 12. So we all know that PDA is a patent ductus arteriosus. I made a mnemonic for that. But it's not the PDA, it's the prednisolone, it's the doxorubicin, it's the aspergillase, and the last one is the vincristine. And you know that these 4 medicines we have to give for 4 weeks, and there is 95% remission for that. Now the second one is intensification or the consolidation. For intensification or consolidation is the removal of the leftover blast cells or the tumor forming cells. In that, we have to clarify that area. In that intensification or consolidation, we just treat the leftover tumor-forming cells. The third one is the maintenance, and maintenance lasts for the 2 years. For maintenance, we give what we give for the maintenance. We give the methotrexate weekly, and daily we give the 6-mercaptopurine, and it usually on the OPD basis, outpatient department basis. And there's a 1 pulse therapy for vincristine. So I will tell you one thing also. The side effects of all these medicines you should remember, at least the gross side effects. Like vincristine having some foot drops, so you should know it's frequently asked in MCQs. And the 4th one is CNS prophylaxis. In CNS prophylaxis, what we usually give the cranial irradiation, intrathecal methotrexate. Now the complication of treatment. I must say that this complication of treatment is in that slide. There is one more thing that is frequently asked in MCQs and being asked in all 3 theory exams. That is the second point is tumor lysis syndrome. The first one is bone marrow suppression. The second one is tumor lysis syndrome. We have a clinical case of that tumor lysis syndrome. Let me explain you what happened in the tumor lysis syndrome. In the bulky tumors, there is some chemicals, there are some mediators released and they spread in the body. So what happened? The potassium released, and there is uric acid is also released, phosphate. So the question usually they ask in the foundation of practice, theory and science, and AKP, that what we are expecting in the tumor lysis syndrome, all of them are increased except, or what are the components of tumor lysis syndrome decreased. So everything is increased. Just remember in your mind, everything is increased except calcium. Calcium is always down. So it's very important and it's frequently asked and it's very common also. The treatment of tumor lysis syndrome and why we are giving this hyperhydration because of that tumor lysis syndrome. Because if it will not hyperhydration, we will not give hydration, so there will be disaster. So for this treatment of tumor lysis syndrome, the treatment is hydration, alkalization, and the allopurinol. Why we are giving this allopurinol? Because of this uric acid. Now, the complication of treatment is, third complication is secondary malignancy, and it can be spread into chest, it can be spread into anywhere. And the third, and the second last is a cranial irradiation. And in cranial irradiation, why we are focusing about this cranial irradiation? Because it can lead to pituitary and it can damage to hypothalamus. And the last one is the spinal irradiation. If there is spinal irradiation, if they will spread into spinal area, the spinal cord, then there will be, a stunting of the growth can also happen. So hope so that this will help you. Any questions? Thank you.
Pues
Thank you so much, Dr. Nida, for this wonderful session. I hope all the queries of MRCPCH are clear now. So if anybody has any question, they can write in the chat box. We are always available for your queries, for your questions. I guess
Hello,
that's
ma'am.
all for today's session. Thank you so much for joining us. Thank you so much, Dr. Nida, for this session.
Thank
And I
you.
think we have to end the session now.
Okay, thank you. Thank you for audience. Thank you, Asma.
Thank you so much. Thank you so much.